Afternoon, everyone. Jason Roberts here. I'm back to introduce this final session, and also back from the first session is Paul Williams. Paul is going to tag team with Jean Chai to go through some case studies of the exemplar dosing software, ID-ODS, which Andras gave a very nice presentation on before the break. And so, firstly, Paul is going to speak first. And before Paul does, I just wanted to publicly congratulate him on his fantastic 100-kilometre ultra trail run that he did at the Blackall 100 in mid-October. It was a grueling day of temperatures over 30 degrees. And yep, he ran 100 kilometres and did it in fine style. So well done, Paul. That was an extraordinarily tough event, and I just wanted you all to know that not only is he a great pharmacist and a very smart expert on the topic of dosing optimization, but he's got other things which he excels at as well. So, Paul, over to you.
Thanks, Jason. Thanks for bringing back some traumatic memories. I'm going to struggle to get through this now. Okay, so you can hear me, share my screen. Let's make a start. So yeah, I'm going to run through ID-ODS case study, Vancomycin and Meropenem, and focus on the empiric side of things, and then Jean will do the Bayesian. So the objective, as I said, is to show you the empiric application of ID-ODS. And also just to provide a brief overview of the information required to perform this simulation at ID-ODS. I'll be running through it fairly quickly. I guess down the track, if you want to watch this later and maybe pause it and run through it yourself at the same time, maybe beneficial if you think you'll be doing this down the track. So the case, we're going to keep it fairly simple and just focus on the application of the actual software. So for the Meropenem case, we've got a 55-year-old male, septic shock, likely resistant Pseudomonas, height, weight, and serum creatinine there. The first thing we need to consider when we start will be, for Meropenem, is what is our MIC target? What's our percentage time above MIC that we're trying to target? So for today, we're going to go with an MIC of 2 being Pseudomonas, and for simplicity, we're just going to go 100% free time above MIC. So our target concentration is 2. For this first simulation, what we're going to do is just simulate a few doses, and it will tell us what our predicted concentration will be, which would help us guide which dosing regimen to use when starting empirically. So for this, we're going to do 1 gram 3 times a day over half an hour, 1 gram 3 times a day over 3 hours, 2 grams 3 times a day over half an hour, and 2 grams 3 times a day over 3 hours. So a lot of this Andras has touched on. So the first step, once you're in the software, is to create this unique ID. So you can change this to whatever you would like. And this also will save the files down the track, which I will show you. So we create the file. As Andras has mentioned, in Brisbane, -10 is our time offset. You would have to modify that accordingly, depending where in the world you are. So we come down here to the demographics. So we're just inputting the data, as I've mentioned. So 55-year-old male, 170 centimeters tall, 80 kilos, male. So get that in. And then we move here. So this first example, which is the MCS1 approach, this is this bottom left here. This is where you're adding the different regimens to try this out. So you can see here that I've put in the serum creatinine. I put in 1,000 milligrams 8 hourly over half an hour, and then I would hit add regimen. If I click the next button, you can see it pushes it over here. So what I've done, I've therefore gone back and put 1,000 8 hourly 3 hour and so forth, as you can see. So then I've populated to make these 4 different doses that I want to assess in terms of target attainment. So once I have done this, just to show you some of the other buttons here, this is just your settings for, I don't need to change anything here, but depending where you are, you may wish to change the units. And finally, for the simulation settings, I'll leave this as is. And Andras did briefly mention about some of these parameters that can be changed, probably more for Bayesian, but something just to keep in mind, that's where that is. And we move on to here to optimizer or the PK/PD target. So we've got time above MIC. Our target, as I said, we're going with 100%, and our MIC is 2 here. So that's set for how we want it. You can see here percentage isolates of MIC. I can't show you where they are, but they're preset with 13, and they'll start quite low and work their way up well past that MIC of 2. And you'll see that in a minute when I show you the cumulative fraction of response graph. Once we do this, we hit the MCS1. And this is what it produces. It produces probability of target attainment and cumulative fraction of response. You can click either of these buttons and it will make a larger image of that, and you can also save these. So just going into the probability of target attainment, I've just highlighted an MIC of 2 because that's what we were aiming for. Very hard to read on here, sorry. But you can see for the MIC2, if we start at the bottom here, which if you go across here, we're looking, under 50%. That's your 1 gram 3 times a day over half an hour. That's 1 gram 3 times a day over 3 hours. That's 2 grams 3 times a day over half an hour. And finally, the prolonged infusion of 2 grams 3 times a day over 3 hours. So you can see the 2 grams 3 times a day over 3 hours has a probability of target attainment of around 70%. So that's the highest of those. You could keep playing around with that in different ways to try and get that up. But for today, for this demonstration, you can see that's the variation. And also to note there, you can see that it's got the creatinine clearance calculated there. So I guess this is to be expected in a patient of this age and kidney function, that you would expect meropenem to be cleared fairly quickly. So if we were really trying to get above 2, or even imagine if it was 8, if we're going 4 times MIC, the dosing required would be fairly significant. This is the cumulative fraction of response that I was talking about. So this is not just including an MIC of 2, but the range of MICs. And you can again see, starting from the left to the right, starting from the lowest dose and shortest duration of infusion to the 2 grams 3 times a day over 3 hours, that is gradually increasing, but not quite meeting that 90% threshold. The next button I wanted to just show you, once you run these simulations, you have this help button, which is useful for 2 reasons. Firstly, when you hit it, it creates Excel or CSV files, so you can view the data in other ways and also save it. Also, if you had any concerns with the simulations, by hitting that, you can then put that in an email. If you were sending it to the email address above, they can have a look at the simulation that you've run and provide feedback regarding that. This is the files that you'll get. I won't go through all these, but I'll just touch on 1 or 2 of them. This is just taken from the spreadsheet looking at probability of target attainment. You can see this is actually cumulative fraction of response, because you can see all the MICs, what the target attainment is. So for example, you see all those zeros, that's why it's pushing that cumulative fraction of response down quite low. But if we focus on the 2, it's just another way of displaying it, that you got 40% probability of target attainment for the half an hour 1 gram 3 times a day. And you see it increases to there. I don't have the 2 gram doses, but that would go up further. Just another way of visualizing this information. So I want to move to the next approach. So that first one, we gave a range of doses, and it gave us what we would likely achieve in terms of concentration. With this one here, this would be more of, I've got a specific dose and I want to simulate it to see what it would actually achieve. You can also vary this and change renal functions at different times. So maybe after 24 hours, you want to say, well, the kidneys did this. You can simulate it how you wish. I use this version for some current research at the moment. So the difference here is that you're using this banner here to add in the dosing. So you can see here, for this example, I've just used the 2 grams 3 times a day over 3 hours. So you can see I've put in the 2000. I put in a 3-hour infusion, then I would have hit this plus button, which you'll see here. So this gives you how many inputs you would like. So how many times do you want to repeat that dose for the simulation? And for this example, I've put 10 times. So that would be 3 days worth of dosing starting from time 0. Once you do that, you can hit update table and it will populate here. And you can see the times, dosing, the 8 hours apart, comes down here. So then, okay, I've got all my dosing. I've got 3 days of simulations. I've got the patient parameter still in there from the previous one. The only other thing I need to put in the creatinine for this patient. So we go back here, type, we change from dose to creatinine. I put in that value of 65. I need to make sure I change the date and time so that this creatinine corresponds with the commencement of the simulation dosing. And once we do that, we update the table again. And we can see here the creatinine's gone in here. You can note the time here is before some of the other ones, so it would be similar to the first one. This is where, if you look to the bottom here, it gives you a visual representation, those triangles being those doses. Sometimes when you're doing it, you can accidentally set the interval incorrectly, and this is a good visual representation to see that it's spaced out appropriately, so you know that all those are 8 hourly. We can see that the creatinine's here at that first dose, so that looks pretty good to me. So it's good to actually check that before you run it. Once you're ready, you're hitting MCS2 on this occasion, and these are the plots that you get, which are a little bit different to the last one. Again, you hit those buttons and it will expand them. So this one here looks a little different. What you can see here, first of all, is the black line here is your median concentration at any time point. I'm not in the software at the moment, but if you hovered at any point, it will show you what that median is. Also, the darker purple is the interquartile range, so that's your 25th to 75th percentile. And then the outer lighter purple or blue is the 10th to 90th percentile. So you can see the range. It just gives you a little bit more information. Generally, if you get one value with the dosing software, it would be the median value. So I guess you just need to be aware that that is what it is. It's a median value. So you would expect it's the middle number. You've got a 50% chance that there's all those values that are below. So I guess it's deciding what you consider to be a reasonable prediction of you achieving that concentration. So I do like to see the 10th, 25th. And then you've got the probability of target attainment, and that is all your doses there. And you can see it's around 68%, which aligns with that MCS1 simulation that we did. It was just under 70. So again, you can hit help, you can get these outputs. So this is just one, this is the CSV file. What we've got here is exactly what I was showing you before. We've got all these extra information. So from the minimum, maximum, 10th, 25th, 75th, 90th. And I've just highlighted here 48 hours. So if you were simulating and everything remained the same, you wanted to know, well, what's the chance, what concentration would you expect? So you can see here that the median is 4.3. And if you go down to the 10th percentile, you've got 0.27. So yeah, so as we've said, there was 70% probability of target attainment with this dosing regime, but it's another way to visualize that. That's it for the empiric Meropenem. I'm going to move on to Vancomycin. Again, we're just going to keep the case fairly simple. So we're going for a 55-year-old male, septic shock, likely infective endocarditis, IBDU, likely MRSA based off history. This time we've got 180 centimeters tall man who weighs 150 kilos with a serum creatinine of 160, creatinine clearance around 50. This time we're going to target an AUC over MIC of 400, and we can have a look as well at a trough of 15 to 20. We're going to do two different approaches here. The first one is using the basic functionality in ID-ODS, and this will predict a loading dose and a maintenance dose. And all you have to do is put in the patient's specific parameters and their serum creatinine, and it will do the rest for you, only for an AUC MIC target. Then we'll change the settings to an advanced functionality. We can simulate specific loading doses and maintenance doses to predict either an AUC over MIC or a trough target concentration. So let's move into this basic model, skip through this pretty quickly. So we've got vancomycin, create your unique ID, put in the demographics of the patient. The difference here in the Meropenem one, we created the dosing regimens down the bottom left here. We don't do that with the Vancomycin one. Up here, we go to the simulation settings and we're making that functionality basic, and it will have empiric written here. Once we've done that, our method we're using is ID-ODS for this one. We want it to predict a loading dose. We want to look at AUC over MIC. We're going to target 400 and we're going to set the MIC at 1. So once we've done that, as I said, all you need to do is put in your serum creatinine, which for this case was 160. Put that in, goes there. We can see there's one value there. Hit empiric, and this is what it's going to do. Again, we'll go in closer. We can see the creatinine clearance that it's calculated from this model is 49. So what the software has predicted is a vancomycin loading dose of 2 grams. This patient weighs 150 kilos, so it's a fairly low loading dose. And we've gone for 1,000 milligrams 12 hourly. What you can see here, I actually hovered just before the 4th dose, which was here. So you can see from a trough perspective, we're looking at a median of 18.5, which seems fairly reasonable. If we click here, this is the AUC over MIC ratio. Dose 1, dose 2, I would look at dose 2 in this one. This here is all just the median here. So you can see we've got the red target of 400 and that's sitting just over 500, which is not too bad. This represents the interquartile range, so 25th to 75th percentile. The day 3 here, this is something that needs to be looked at in future iterations. What has happened here, it's dropped off, but that's because the simulations for this simulation, excuse me, the simulations have stopped at a time point just before the 72 hours, so it's seen a dip in that. So that's something that the software ID-ODS are aware of, but at this point, if you were to use it, look at that second one. Again, there's an output, and you can see here, I've gone to 36 hours, so pre-4th dose. From a trough perspective, you can see that looks fairly good. AUC, you can see again, if you go median, it's 559. If you're looking at 10th percentile, so 90% are above that, 378, that looks fairly a good start. So the last one, sorry, I'm just gonna have a quick drink. The last simulation is just the advanced functionality. So I thought for this one, I'm gonna simulate. I'm not happy with that. I don't think that loading dose is high enough. Let's try something else, see what happens. Creatinine clearance is around 50. Let's just go all out and give a good loading dose and a good maintenance dose and see what it predicts. So for this one, we're going to go 30 milligrams per kilo as a load, and we're going to follow it with 15 milligrams per kilo twice a day and see what happens with that degree of renal impairment. Let's see. So if we go back to the top here, if you remember that was basic, we've now changed that to advanced. The method, which was ID-ODS, we've had to change this to a 2-compartment population PK model. So it's using a different population model now to predict. So you need to change that. We've still got the AUC targets exactly the same. As you can see here, I put that load in of 4,500. I've simulated, I think I did about 10 doses of 2,250. We can see it spaced nicely. I've put in that serum creatinine, which was 160, I believe, and you can see that sits there. Looks all good. When I've changed it to advanced, that empiric now, the wording has changed to this MCS 1 and 2 and Bayes 1. And then I hit the MCS 2 and we'll see what we get. From here, this is looking a little scary. Let's go in closer and have a look. So you can see here, we've got our load and we've got our subsequent doses, and you can see we're getting some nice accumulation here. Again, I've hovered pre-4th dose and we can see that the medium concentration predicted is 47.9, so getting a bit high. If we go to the AUC over MIC, we can see the red dotted line, which is showing us our 400. We can see here we've got 1,000 as a reference. We can see the median, even from the load, is higher, getting higher and higher, with the interquartile range getting higher too. And if we look at the outputs, if we're looking at the trough concentration, you can see here, even 10th percentile is 29.3. And the AUC, if we're looking at the median at day 2 or day 3, you can see it's just getting higher and higher, and the 10th percentile is well above 2. So that would suggest that if you were to do this empirically, that low dose followed by twice daily vancomycin and a creatinine clearance of 50 in this patient is probably excessive. So I know I've run through that fairly quickly, but hopefully if this is something you would like to do, you can run through it slower at a later date. I just find with this software, just actually using it and running through it and having a play is probably the best way to pick it up. I think this empiric software has a place in clinical practice. You need to, as probably been said many times today, you need to have the knowledge or information to be able to utilize it. And I guess the next step from here, you've got empiric, but I think where it would really shine is with its Bayesian modeling, and that's the focus of the next case, which Jean will be taking from here. So thank you.
Excellent, thanks, Paul. There doesn't seem to be any questions online, so I might now introduce Jean again to now give his working demonstration of the Bayesian forecasting functionality within ID-ODS. Thanks, Jean.
Right, thanks, Jason. I'm just going to quickly start my presentation. Yeah, that's a good point. All right. So I'll be giving a presentation today on how we've used Bayesian dosing programs specifically to optimize the dose of Meropenem for a case that we had in the ICU here at the Royal Brisbane Hospital. Because Andres and Paul have really done a great job actually showing you the functionality of the program, I won't be going through that. This will purely be a description of the actual case. Now, initially, this was meant to be run as a workshop, but unfortunately with COVID, everything has to be done virtually. So I'll try to make this as interactive as possible. You will notice throughout the talks, there'll be a few polls for the audience to participate in. It'll be interesting to see what sort of answers we get from the group. So I have no conflicts of interest. So the case that we're going through today is a 65-year-old man who was initially admitted into a private hospital. He had a laminectomy about 2 days ago because he's got a chronic spinal stenosis. Now, this was unfortunately complicated by 2 dural tears, which were actually surgically repaired intraoperatively. Now, he eventually was transferred over to the Royal Brisbane because unfortunately he did not have private insurance, so he was unable to stay for longer than that in the private system. Now, in terms of past medical history, nothing terribly exciting. He's got hypertension, which he's being treated with a blood pressure tablet, and he's got sarcoidosis with cardiac involvement, but that's just undergoing active surveillance with his cardiologist. Now, while on the wards, he was having frequent MET calls or medical emergency calls for hypertension, and the staff probably thought he was starting to become a bit delirious. So the orthopedic surgeon actually sent the patient for an MRI spine to actually see what was happening at the surgical site. And what they found was he actually had an epidural abscess between L2 and L3. The surgeons quickly brought him back into the operating theatre for an immediate washout, which was successful, but he still required significant vasopressor requirements, so he was sent to the ICU, essentially for monitoring with hypotension post-op. Now, in terms of his clinical assessment when he actually arrived in the ICU, he was intubated with an FiO2 of 25%. Sorry, that should be 99. So he was actually saturating quite well. That would be pretty bad. He was maintaining his MAP at 70, but that was on quite significant noradrenaline requirements. He was afebrile and GCS3. Now, in terms of information specific to the infectious diseases side of things, his white cell counts were slightly elevated at 12.7. His neutrophils were 11. And for those of you who believe in CRP, his CRP was back at 262. So some sort of inflammatory and infectious condition happening in the background. Now, the surgeons were kind enough to send off an intraoperative sample, which actually came back with Enterobacter aerogenes. And you can have a look at the sensitivities there. It's a fairly sensitive strain. And when we actually looked at the blood cultures that he presented at the hospital with as well, he had the same organism growing in blood. Now, we elected to go ahead with Meropenem because we thought that would probably have the best CNS penetration of all the different antibiotics there. We'll just briefly go through the properties of Meropenem again, just in case you're not terribly familiar with them. So being a beta-lactam, it exhibits time-dependent killing. So the efficacy of Meropenem is best described by the duration of time that the concentration of Meropenem remains above the MIC. Now, if 20% of your dosing interval is spent above the MIC, Meropenem seems to exhibit bacteriostatic effects. So it kind of slows the rate of growth of bacteria, but it doesn't really kill it per se. That might be sufficient in a patient who is not critically unwell, has a very low disease burden. The patient's immune system can take care of the rest of the Enterobacters. But if you want a bactericidal side effect or property, you need to increase the duration of the dosing interval that exceeds the MIC by at least 40%. Meropenem is not really highly protein bound, it's only 2%. In terms of the licensed dose, it's actually 1 to 2 grams up to 8 hourly. So according to the product information, you're able to give a maximum of 6 grams in a day. Now, the toxicity threshold for Meropenem is not very well defined, but preliminary studies by the group by Amani in New South Wales suggest that once you start hitting a trough concentration of between 20 to 25, and that's with intermittent dosing, you start to see an increased risk of potentially neuro and nephrotoxicity in your patients. So just keep that in the back of your mind. So I'm going to open up the poll to everyone. What do you think the target trough Meropenem concentration should be for this particular patient? So do you think it should be 2 milligrams per liter? Should it be 4 milligrams per liter? 8 milligrams per liter or 16 milligrams per liter? Some of you might be wondering, what is the Meropenem level? I've never seen one before. So I'll keep the poll open for about 30 seconds. So you should see it pop up on your screen. If the audience would like to start voting, I can see 1 vote so far. Ooh, quite a distribution. Almost looks like a normal distribution. It's getting less normal now. Oh, no. All right, I might end the poll there. So a majority of the people seem to suggest that they would target 8 milligrams per liter. Seems like about 20% of you have never actually heard of a Meropenem level before, which is not quite surprising because not many centers actually do it. So I just want to preface this by saying there is no right or wrong answer, but this is kind of what we did, and this is the reason why we did it. So we actually went for 8 milligrams per liter, and that's for a couple of reasons. Now, at the Royal, we don't tend to measure an actual MIC for most of our pathogens. So even though we know that this particular bacteria is sensitive to Meropenem, we don't have an official MIC. So the way that we tend to approach our dosing is by actually looking at the EUCAST breakpoints. Now, we've heard a little bit about these breakpoints from some of our earlier presenters today. And the easiest way to think about a breakpoint is the highest MIC that your pathogen will display before being deemed resistant to Meropenem. So if your bacteria's MIC is 2 milligrams per liter, that means that bacteria will automatically be classified as sensitive to Meropenem. If it's 3 or more, then it will be classified as resistant. So in this case, we went with the breakpoint of 2 milligrams per liter. Now, the other thing to consider as well is this patient's infection is not actually in the bloodstream. So the level or concentration that you're getting in blood may not necessarily be reflective of what you're actually seeing in the central nervous system. And it's almost more than likely going to be much lower than what you're seeing in blood. So the actual variability of CNS penetration is quite large, and it's really dependent on the degree of meningeal inflammation that the patient is experiencing. And the concentrations can vary by over 10-fold between low meningeal inflammation or someone who has really highly inflamed meninges. So in this particular case, we elected to go with 4 times above the MIC. So that would give you a target concentration of 8 milligrams per liter. Now, I just want to preface this as well. We've seen through our earlier presenters today that the breakpoints are not the only thing that you have to look at. You can also consider the wild type distribution for Meropenem with Enterobacteriaceae. So if you actually look at the bottom here, it tells you what the distribution of MICs are for all of the organisms that you can find, not in nature, but in the clinical environment, I suppose. And overall, they're actually quite sensitive to Meropenem. So averaging of an MIC of about 0.03. But I suppose it's highly possible that you might have a strain that sits somewhere in the middle here, which is why we've elected to go with the 2. So it's kind of a be better safe than sorry approach. So these are some of the relevant parameters that might influence your dosing recommendations. So the patient is 130 kilograms, so a fairly large patient, average height at 170 centimeters. His BMI works out to be 45 and his creatinine is 77. So relatively good renal function. So we're going to open up the poll again. What dose of Meropenem do you think that we should use to achieve that target concentration of 8? And I will launch the poll and I'll give everyone about 30 seconds to select your answer. Oh, it's not as. Oh, everyone seems to be going with 2 grams 8 hourly.
Target, are you hoping for?
8.
Trough.
Trough, yeah. All right, I might end the poll there. So we've got a distribution of answers. The majority of, oh, actually, let me share the results to make sure that everyone can actually see it. The majority of people in the audience seem to suggest that 2 grams 8 hourly is the empiric dose that we should go for. Some of us seem to be happy to actually target a slightly higher dose, so 2,000 milligrams every 6 hours. Yes, I'm just trying to close that. Now, we have seen these plots in the previous presentations earlier today, and this is a plot that's generated by ID-ODS. Now, I want you to think of the x-axis as antibiotic or Meropenem concentrations, not MICs as you might have seen in your previous presentations. And on the y-axis, you can see the probability of achieving a target concentration based on the x-axis. So remember, we're targeting 8 milligrams per liter, and you can have a look and see even with 2,000 milligrams every 6 hours, the chances that you will actually achieve a trough concentration of Meropenem of 8 milligrams per liter is only about 45 to 50%. So the pharmacokinetic model that's in ID-ODS seems to suggest that none of those options would have worked for our particular patient. Nonetheless, we went with the audience suggestion, and we actually went with 2,000 milligrams every 8 hours because that just seems to be the standard dose that most people will use for a CNS infection. So a little bit more progress information. So we've commenced the patient on 2 grams every 8 hours over 30 minutes. In terms of his infectious disease pathology, his white blood cell count hasn't really changed much. His neutrophils has gone down a little bit. His subsequent blood culture that was taken the next day is negative, but obviously that has only been incubating overnight. And the patient is still afebrile. Now, the surgeons requested for a repeat MRI because that was in their postoperative instructions. And what the MRI actually found was that the infection had recollected at the surgical site. And the doctors were concerned that the patient was not being adequately treated with the Meropenem. So we actually measured a trough concentration based on the 2 grams over every 8-hour dose. And the Meropenem concentration came back at 2 milligrams per liter. So this was taken at the right time, and it is definitely a trough concentration. So I'm going to open the poll for one last time. Oops. What dose do we think this patient should receive in order to get that trough concentration of 8? So the first option is 3,000 milligrams every 8 hours over 30 minutes. So the total daily dose is 9,000 milligrams. Or we're going to give 2,000 milligrams over every 6 hours, which is the same dose, which equals 8,000 milligrams? Or are we going to do an extended infusion, but do it with the 8-hourly dose? Or are we going to do it with a 6-hourly dose as an extended infusion? Or is this just too hard, and can someone else do the math for me? Ooh, people are still voting with this one. All right, I might end the poll there. Share results. So most of us seem to think that we should go ahead with the 2,000 milligrams Q6H as an extended infusion. Now, I'll admit, at the Royal Brisbane Hospital, we thought this was too hard and we just want someone else to do the math for us. But it's good to see that most of you had an idea of what dose you were going to use. So we actually popped all of that information into ID-ODS. And what ID-ODS seemed to suggest is that we should have used a dose of 2,000 milligrams given every 6 hours, but administered as a 3-hour infusion as opposed to a 30-minute bolus injection. So Andres has kind of gone through what this graph means, but I'll just quickly go through it again. In the black line, you have the simulated concentration over time profile for your patient based on their current dosing regimen. So you can see we get really high meropenem peaks, but the concentration dips below our target of 8, which is shown by this little red dotted line here, for quite a significant time of during the dosing interval. This little diamond shape here is the actual concentration of 2 milligrams per liter. And in the right here is a simulated concentration time profile that you would achieve if you actually selected this dose of 2,000 milligrams every 6 hours and given the infusion over 3 hours. So you can see, even though we don't get quite as high a peak as we did with the other dosing option, we have significantly increased the amount of time that the trough concentration would be above the MIC. And in this particular case here, it would have been about 7. So just to continue on with the case, so the patient did end up receiving that dose, and the predicted trough was about 7 milligrams per liter. And when we repeated the concentration a day later, it came back at 12.1 milligrams per liter. Now, bear in mind, this particular concentration was actually taken about an hour earlier than we would have liked to. So if we did actually take it as a true trough concentration, it probably would have been a bit lower at about 9 or 10. So we've definitely achieved our target of 8 milligrams per liter, but how confident are we that we've actually achieved an adequate CNS concentration in this particular patient? Well, thankfully, the patient actually did have an extra ventricular drain, so we're actually able to sample CSF in a non-invasive fashion. And what we noticed is when we actually took the sample, the free meropenem concentration in CSF was actually 1.5. Now, this wasn't exactly a trough concentration just because they weren't able to collect the CSF at the right time, but it was roughly midway through the dosing interval. So it's not exactly our target of 2 that we were aiming for in blood, but we were actually pretty happy with that. Because if I bring you back to this particular table here, we can remember that even though we're aiming for 2, the majority of Enterobacteriaceae are actually quite sensitive to meropenem. So this concentration of 1.5 would probably cover most strains of Enterobacteria, even if it's in the CNS. So this is just to give you a visual representation of what the other alternative dosing regimens would have looked like. So if we actually gave meropenem 2,000 milligrams every 6 hours over intermittent bolus, that was essentially the dose that we're on. So you can see that the concentrations dip below the targets quite frequently. If we did over a 3-hour infusion, but actually gave it 3 times a day, didn't really change the amount of time that we actually exceeded the MIC. If we went really aggressive and gave him 9,000 milligrams of meropenem a day, yes, we get even higher peaks, but it still didn't really change the amount of time that the concentrations dip below the MIC. So I suppose the key message that I hope most of us can take away from this presentation is that TDM is really useful for a wide variety of antibiotics, not just the aminoglycosides and the glycopeptides that we're used to sampling. In certain cases, like in this particular case here, where your site of infection is not in the blood or close to blood, or there is a separate barrier that's preventing antibiotics from penetrating into your site of infection, you might want to consider slightly higher targets. Where possible, and I understand that this is not always possible because of the invasiveness of these tests, but where you can, try to actually sample the concentration of the antibiotic at the actual site of infection, because that will probably give you more confidence than trying to extrapolate it from blood. And remember, just by increasing the dose doesn't necessarily mean that you'll achieve your pharmacokinetic or PK/PD targets, especially when we're talking about antibiotics that exhibit time over MIC PK/PD profiles. And dosing software is obviously quite useful whenever you have tricky situations such as this, where the degree of dose escalation is not quite as clear-cut as that you can see in other cases. And I'll leave it at that. Thank you. Oh, it's a question. Can we incorporate our own priori for ID-ODS software? I'm not quite sure I understand that question. Jason says no.
I don't think there's capacity to do that. I think you'd need to go into the back end of the program to put in that kind of information, because that really is parameter estimates that you're trying to propose for that individual patient. I don't think there's capacity in the fields to add in what you would propose that to be. So maybe if Andras has joined us online, he could comment, but otherwise you'd be very welcome to email Andras through ID-ODS or any of the other software providers as well to see whether or not they have a different approach to this. I have a question for Jean, and it relates to that issue that you had about target site concentrations, so tissue concentrations for want of a better term, versus blood concentrations. And what you did answer this in your presentation, but I just want this to be absolutely clear that when you are trying to choose a target for use with software of any kind, or even if you're just using TDM without software, how you would go about choosing a target based on an MIC. So if you've got an assumed MIC because you have an ECOF value that you're happy with, in what situations may you choose a different target to that ECOF because of the site of infection?
I think that it's not quite a clear-cut answer, because I think you really need to consider what's actually happening to your patient. Because if you have a patient where you're aiming for 2 milligrams per liter and the patient's actually showing clinical response and you're satisfied with the degree of clinical response, then you may not actually need to target higher. Because like we've seen in this Meropenem example, even though the ECOF is 2, the actual distribution of MICs is probably going to be a lot lower in reality. Having said that, in this particular case here, even though we did achieve that concentration of 2, there was clearly disease progression. So in these settings, I think it's probably more relevant or more appropriate to be pushing slightly higher targets.
Great. And so in what situations would you choose a higher target? So what infection pathologies and what magnitude of an MIC might you choose? So, for a ventriculitis or a meningitis, would you think that you may use different targets for those, or a pneumonia in a patient that maybe has chronic obstructive pulmonary disease and has fibrotic lungs or something like that, or a patient who's got severe septic shock, has a very high vasopressor load, has a mottled appearance to the skin but has a skin and soft tissue infection, as examples of scenarios whereby maybe you're not going to have equal tissue concentrations versus blood concentrations.
Yeah, so in those settings, empirically, I'd go with 4 times the MIC, because that's the most common target that's reported in the literature. And then the other thing to consider as well is toxicity. So Meropenem doesn't have a very it has a slightly higher toxicity threshold, but if you were dealing with something like cefepime, where you start to see neurotoxicity at about 20 milligrams per liter, and the breakpoint is only about 8, targeting 4 times the MIC in that setting is probably going to be inappropriate, because your risk of toxicity is going to be outweighed by the risk of any potential benefit from doing that approach. Yeah.
Great answer. And in terms of what those toxicity thresholds are, there's some data which is in that position paper published in Intensive Care Medicine in 2020, and some of the strongest data included in that comes from a paper from the University of Sydney and St Vincent's Hospital in Sydney from Indy Sandra Dura and Debbie Marriott, published in JAC maybe about 2016 or so. That's something which is very worthwhile looking to see exactly what toxic thresholds they defined. So, all right, well, with that, I'll thank Jean and also Paul for their presentations. They were very, very interesting, and I hope that you all found them very worthwhile. This ends the afternoon session. So we're nearly 3/4 of the way through this extravaganza of therapeutic drug monitoring related presentations. This was the final presentation from the Brisbane component and the Oceania contribution to the day. In 1.5 hours from now, so 6 o'clock Brisbane time and 9 o'clock European or French time, we're going to hand over the reins to Professor Claire Roger at CHU Nimes. As I mentioned at the start of the day, Claire is an intensive care physician, and she's certainly been very busy with the second wave of COVID cases that has emerged in Europe over the most recent weeks. So it's great that she has been able to convene this next part of the program, which I'm sure that you've all seen, and we really look forward to hearing from our European friends about some of the different topics which they've brought together. So once again, thank you very much everyone for your participation so far today.